Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today, in our Conversation with Cancer Expert series, we have Dr. Samir Hadidi, who is assistant professor at the Myeloma Center at University of Arkansas, one of the centers that has made tremendous contributions to multiple myeloma over the decades. And we're glad to have him today to talk about will CAR-Ts and bispecifics eliminate transplant for myeloma. Little Rock has been at the vanguard of getting transplants, up and being the major modality of therapy for patients who are eligible. So I'd be very interested to see what Samir thinks about this. So welcome, Samir.
Thank you so much for having me.
So what we're going to start out with, I guess, is just a discussion of where CAR-Ts have been till recently. So can you tell us where you have used CAR-Ts in the last couple of years, and then we'll see where we are today and where we'll be in the future.
No, I think that's a great starting point. We have nowadays 2 approved CAR T cell therapy in multiple myeloma, and those have a journey, of approval. We have a cell-to-cell and ide-cel, and both of those agents were used in patients at a later stage in their relapse. So those patients got on a median 6 prior lines of therapy, as you can see on the slide. And in the initial studies were single arm studies where patients who have very limited options, if any, got those products. And when they got it, actually, we got really, promising responses that are durable for such patient population. So in the case of ide-cel, the development program was called KARMA studies, and the initial study did result in a progression-free survival of around 9 months. Now, this also was associated with a very high overall response rate of 73%, and patients got deep responses, which we call them CRs or better, in around a third of cases. When it comes to the cell-to-cell, it's a little bit the newer kind of kid in the block, the newer CAR-T. And it was also studied in a program called CARTITUDE studies, and used in patients with multiple lines of therapy, and in this case, 6 lines of therapy. And the progression-free survival, it was relatively longer compared to the ide-cel. But those products, as we all know, were never kind of compared against each other. Actually, the most recent cell-to-cell progression-free survival was around 35 months, which is quite long for such patient population who received multiple lines of therapy. And the overall response rate for this product was almost 100%. 98% of patients did have some sort of response. So those are really promising agents in those later lines. And that's why we got both of those agents approved initially to be used after at least 4 lines of therapy in the US.
So obviously now we very recently have had the ability, based on some trials that we'll go over, to use these in earlier lines. So what can you tell us about the KARMA study?
Yeah, I think, KARMA-3 study did look into ide-cel compared to other multiple myeloma regimens we use at an earlier lines of therapy. And I want to draw the attention of the listeners to the eligibility criteria for this study. Patients got 2 to 4 lines of myeloma treatments before, including a drug called daratumumab, which is an anti-CD38 antibody, a proteasome inhibitor, and an immunomodulatory drug. Those patients have a relapsed disease, and they either got ide-cel or got a standard regimen. And you can see those regimens listed there as 5 of the regimens that are approved to be used for patients who have relapsed refractory disease. And this trial design, the randomization was 2 to 1, so more patients got ide-cel compared to standard regimen. And if you look at those patient characteristics in the table, you can see that those patients, the median age was similar. There's lots of similarities in this baseline characteristics because this is a randomized study. So we want it to be that way. We also got important features to highlight, including the high-risk cytogenetics, patients who are refractory to anti-CD38 or daratumumab were almost 95%. And that's very, a difficult patient population to treat. And with that being said, that was a study that is randomized, which is different than the initial study we discussed. So such randomization will allow for a better characterization of the efficacy and the safety. So, and this resulted actually in also improved outcomes, which we will discuss here. So here, as you can see, this is the median progression-free survival because this was the primary endpoint of the study, and the use of ide-cel did result in improved progression-free survival compared to the other regimens that were used as standard of care. And that was around 14 months compared to only around 5 months for the standard of care regimen. And that achieved the primary end goal of the study, which is improved progression-free survival at an earlier line of therapy.
And what can you tell us about cilta-cel? How has it moved into earlier lines of treatment now?
Yeah, I mean, we're lucky now that we have two of those products available, and the CARTITUDE program did look at cilta-cel compared to standard of care. But I want to draw the attention of the listeners to the eligibility criteria there. You can see here patients got 1 to 3 lines of therapy, so it was a little bit on an earlier setting compared to the KarMMa program that we just discussed. Those patients were limb refractory, but not necessarily anti-CD38 refractory. And those patients were randomized to get either a standard of care or a cilta-cel in one-to-one fashion. If we look actually at the patient characteristics, those patients are also split, in a good fashion because of the randomized portion of that study. We have high-risk cytogenetics also represented there. But the patients who got, refractory to daratumumab was around 20% to 25% only. And that is important because we tend to kind of compare those products against each other, but they're never being compared against each other in the same patient population. So we need to keep those, things in mind when we govern the responses we got by both of them. The primary endpoint here was also progression-free survival, similar to the prior trial of ide-cel.
So what was seen in terms of results?
The results here were really promising, as you can see on an intention to treat analysis, which is an important analysis we do specifically in patients who we plan to give CAR T-cell therapy. And I just want to make everybody aware of this concept of intention to treat. That means if you decide to give patient a CAR T-cell therapy, and even if they didn't get it, you still actually look at their responses and outcomes as if they got it. And that's quite important because this way you kind of show the actual real benefit that you use in the clinic. With that being said, that with a median follow-up of more than a year, the 1 year progression-free survival was better for cilta-cel, as around 3/4 of patients responded compared to 50%, and they were progression-free at 1 year. And you can see patients who got better responses tend to be patients who got less line of therapy in general. Those patients got better responses overall compared to patients who have more lines of therapy. There were also some trend towards improvement of overall survival in the early readout of the CARTITUDE-4, which we know now with a recent FDA meeting that occurred in 2024, that this overall survival seems to be translating to an actual overall survival. One thing I want to point here, comparing both the CARTITUDE-4 and the KarMMa-3 study, the CARTITUDE-4 did not allow for a crossover, but KarMMa-3 did. So that means if patients progressed on the CARTITUDE-4 study, they did not automatically got to get kind of cilta-cel. A small number of patients actually got it because their physicians did provide them with that, but that was not the standard of that study, which was a little bit different than the KarMMa-3 study, where half of the patients actually ended up getting ide-cel when they progressed from the standard care arm.
So before we get into how these are now going to move into even earlier lines, where do you anticipate using CAR-Ts now that they're approved for second line and beyond?
Yeah, I think that's a great question. I think the most important use for those products will be in patients where we don't have really good outcomes with. So there are patients, for example, who get a triplet or quadruplet-based regimen induction. They get a transplant, and shortly after transplant, they relapse. And such patients, people do refer them as functional high risks, who have actually short sort of control. CAR T cell therapy tend to be, my go-to option because it's first of all, it's a different target, which is BCMA in that case. And second of all, those patients may enjoy prolonged disease-free interval where, that will be important for the quality of life. And number two, that this is a really difficult patient population to deal with, specifically in cases of daratumumab refractory or anti-CD38 refractory cases. So I think we'll be using more of those products early on in this subset of patients who are functionally high risk, or patients with high risk disease in general, because of that poor prognosis for that subset of patients.
So now, obviously, we're also looking at moving these into the very front line of therapy. And the thing is that in that regard, we have seen data from ide-cel in patients who have had less than an optimal response to transplant, first of all, already presented. Can you enlighten us about this potential use for the drug?
Yeah, I mean, we're trying to improve in what we have, and I think those are important concepts to test. And in this specific cohort of CARMA programs, patients who got a transplantation and got less than, a very good partial response to their treatment did actually get ide-cel, and that resulted in, in deepening of those responses for those patients and improving those responses. And that's important because we know that patients, for example, who go into transplant, if they get better, deeper responses, they tend to do better than patients who get less than, those deep responses. So the idea was if we kind of give patients such a product for the less than ideal response, are we improving or not? And I think this is, things that we will continue to follow up in the future to see the durability of those responses, and also more importantly, how patient outcomes will be. And as you can see here from that slide, with a follow-up of 36 months, the duration of response was quite promising at 81%, and the progression-free survival also at the 3 years mark was 76%. And those are, quite important to study and figure out in the future.
So talking about the future, I guess they are starting to try to figure out that. So what can you tell us about the KarMMa-9 study?
Yeah, I think now we want to try to see if we can improve on what we have in a more of a randomized fashion. So what we're trying to do with the KarMMa-9 study, we want to see in patients who were otherwise we do a transplant on, is doing ide-cel will result in better outcomes than patients who get a transplant. So this is the, one of the studies that will look into this question specifically. Those patients will either get a transplant or they will get a ide-cel, and they will be maintained on a Revlimid. Now, to the audience, maintenance of Revlimid is something we usually do after transplantation. We don't usually do after CAR T cell therapy, but those studies are built in a way to be sort of similar in the actual product and what follows after the product. And so it would be important to see if anything we can be able to beat a transplant in the future. And I think that's one of the things that we'll be exploring in the future.
So obviously the Holy Grail is to move it right up front. And there are trials now ongoing, looking at both the population that is going to go to transplant and those that are not going to go to transplant. And can you tell us about these trials briefly?
Yeah, I mean, those are two phase 3 trials, as you can see, CARTITUDE-5 and CARTITUDE-6. CARTITUDE-5 is for transplant not intended or eligible. CAR-T6 are for transplant eligible. I think the one that answers the big elephant in the room question is comparing an auto transplant with an actual cell-to-cell, or in this study is CAR-T6. As you can see, those patients get, induction with a quad-based regimen, which is DARA-VRD. They get an auto transplant. They get a consolidation quad-based regimen, and then Revlimid maintenance for 2 years, or they will get, a CAR T cell therapy after 6 cycles of their VRD. So here the question will be, is cell-to-cell better than auto-transplant? And that will be important to figure out with this randomized phase 3 trial. In the case cell-to-cell, win a transplant, then we will have, something that in a phase 3 trial that result in such a benefit, and that will likely get the CAR T products approved, and will be likely replacing transplant in that scenario.
So obviously you mentioned that we will be a while before we know the answer to this, that it could be replacing transplant. I also know that transplant-focused doctors are looking not at transplant or CAR T, but they want to look at transplant and then CAR T in a sequential manner as well. So can you tell us a little bit about that approach?
Yeah, I think that is a very interesting approach to look into. Back in the day when we used to do too much of the tandem transplant, for example, which was back-to-back actual transplantation. This is sort of different, kind of looking into those sequentially to try to eradicate sort of all the myeloma clone and result in prolonged, a survival and why not cure. And I think the reason of doing that is likely for a subset of patients where they don't get the actual full benefit of the transplant, which is, a CR, for example, a stringent CR, or MRD negative, for example, bone marrow. And in those subset of patients, trying to do some sort of extra thing after it, maybe, scientifically a valid question to ask and see if that will be the way to go.
And obviously, the other hot area of drug development in myeloma has been the bispecifics. And how do you think that these are going to intercalate into the transplant paradigm?
Yeah, I think it's the bispecifics, we're really lucky to have 3 of those bispecifics nowadays because, first of all, those bispecifics overall response rates were really promising. Around 2/3 of patients with really relapsed refractory disease, later lines did respond to those. So that's where the excitement come to those agents. This is way higher than the single agent, that we used to have before, where most of those got approved with only 1 out of 3 patients responding to those products. So here you can see there are multiple, development programs. The Majestic program is for teclistamab. The Magnetism program is for erlonetamab. Both of those are actually BCMA targeting bispecific antibodies. And both of those studies listed here on the slide are looking into the newly diagnosed myeloma patients who get, induction and followed by auto-transplant. And accordingly, they will be randomized in the Majestic program to get teclistamab alone, lenalidomide or Revlimid, teclistamab and lenalidomide. And this is a big study. There's 1,500 patients planned to be enrolled in that study. And the primary endpoint is to look if any of those 3 will be better. And I think that's important to keep in mind that we don't want to just better responses, but we want to make sure that those options are safe to patients, because there's always concern that if you add more, like teclistamab, Revlimid, for example, could that be resulting in more side effects than teclistamab alone or Revlimid alone? And I think that's very important. When it comes to the Magnetism program, sort of similar patient population there, the number of patients are a little bit lower because there is only 2 arms, either erlonetamab or lenalidomide, and the question asked is if doing one of those is better than the other, because we, as you know well, and the audience, that Revlimid is the sort of the standard of care to do after transplantation, because on the meta-analysis that it was shown to have improved overall survival. But we got along since that time, and we got multiple of those options nowadays that we didn't have before, and it makes sense to check if one will be better than the other.
So obviously a lot happening in clinical trials. Some of these questions will not have answers for a long time to come. But with your crystal ball, what do you see? Transplant being part of therapy, 5 year, 10 year time frame? Or do you think you'll be doing mainly CAR Ts and bispecifics and transplant will no longer be part of your treatment to offer?
Well, that's a great question. I think will be likely long before we get rid of the transplant per se. The reason why I think has multiple things to keep in mind. First of all, a transplant has this old record of a long-term outcomes and safety outcomes, as well as predictable sort of safety outcomes. And we're still learning in the field how CAR T, patients will be doing many years after they get it. And I think time will only tell if those, for example, doing CAR T cell therapy will be as safe as transplant, because transplant is quite safe, procedure we do for patients. And if that is the case, we also need to see how CAR T will be used more often, similar to transplant. We do way more transplant than CAR T cell therapy, even in the US when it comes to myeloma. And the reason why it has to do also with experience. We're way more experienced to give more transplant than CAR T. Those are, the transplant itself are done in the same institutions, does not require manufacturing. But we're only getting better with CAR T. With CAR T, we have better manufacturing maneuvers nowadays, quicker turnover kind of techniques. So I think if I see the coming 5-10 years, there is a good chance that CAR T may replace a transplant or improve on patients who do not get a good response after transplant. And I think both of those goals are really good to achieve. And we'll have the phase 3 trials done, and we will get to know exactly if CAR T will be better than a transplant, and more important, how safe both of those products are given in this young, in usually younger patients and also at earlier stages. And the other thing I want also highlight is if we look only at the data, for example, when you look at the transplant-related mortality is way low nowadays in experienced centers because we're using it for a long period of time. With CAR T, we still have higher than the usual myeloma transplant kind of mortality. And the reason why those patients likely are treated at a later stage, they're likely sicker, but we need to know if one is safer than the other in a randomized fashion. So I'm actually very optimistic that we'll have better than transplant and maybe something that is safer, or more importantly, less quality of life related issues, because we know that transplant is inconvenient because of the side effects that result with it, that is usually short-term and reversible. So we need to learn that portion. But other than that, if there is a safer option that is better, why not? I think that is possible. Now, when it comes to bispecific, I think it's a little bit harder. The reason why bispecifics nowadays are being developed as a prolonged therapy, therapy that goes for a longer period of time than CAR T. So the philosophy of treatment is quite different. So if we develop in the future more of short-term bispecific use, which we're doing nowadays in studies, I think that will be more of an important question to answer if choosing a fixed duration bispecific will be as good as or better than a transplant or CAR T cell therapy. Because now, CAR T cell therapy, has multiple things to kind of compete with. Bispecific is one of them. Bispecific is extremely, available nowadays in a better way. We can use it anytime we want. Insurances are more familiar with it. The approvals of it sometimes happen, on the spot. So I think that's great. The access is really not an issue with bispecifics. And our colleagues in local, community oncology, they're getting more experienced using bispecifics. And I think that's only will get better with time. And we remain to learn how CAR T will be used in a large scale, similar to what we have in the transplant world. So I'm optimistic that that could be the future. Why not? I think we need to improve on what we have, and more importantly, try to improve the quality of life metrics that goes down after transplantation for patients, while keeping the safety as great as transplant.
Well, I really thank you, Samir, for taking the time to educate our audience about this important topic. And as the data emerges in the months and years to come, I hope I can reach back to you to come back and for another program and be able to educate our audience about additional advances in the future.
Thank you so much.
Thank you.